welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters to you, to learn together, and to share some new ideas. I'm Leah Whitehead. I'm the proud mom of a preemie, and I'm also a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, and it's also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or family, I invite you to go over to CanadianPreemies.org, our website, and there you will find resources, the latest projects, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so please bring your voice to the table, leave a comment or question, and we will try to get to those before the end of our program today. It is through rich conversations like these where we can all advance practice and learn together. So please participate and let us know where you're watching from today. Today's topic is Alberta Family Integrated Care, empowering families and shaping healthcare. And it is a very timely topic with the International FICare Conference taking place in Toronto and online tomorrow. FICare, if you don't know, is a model that integrates families as partners in the NICU care team and provides a structure that supports the implementation of family-centered care. Research suggests that FICare decreases parent stress, results in fewer nosocomial infections, improves infant growth and breastfeeding rates, and improves patient safety. And there are so many things that are happening, that are exciting, that's going on with FICare these days. And so we're very happy to be talking about a big initiative that's taking place in Alberta. With the positive outcomes for babies, parents, and the healthcare system I just mentioned, Alberta FICare is now the standard of care in the province. And that kind of change, it takes time. And over the years, Alberta FICare has evolved. And now it's taken another big step to incorporate two new roles essential for its sustainment. And I'm excited to be talking about this new initiative today with three amazing individuals. Firstly, we'll be joined by Karen Benzies, a professor of nursing and director of social innovation at the University of Calgary. And she's attained over $35 million in research funding and published over 160 articles. Dr. Benzies designs, evaluates, and mobilizes interventions to improve parental health and child development, which was recognized by the Health Quality Council of Alberta. Alongside Karen, we'll also have Amanda Moe. She's the provincial practice lead for Alberta FICare and an experienced neonatal nurse who has previously supported Alberta FICare on the front line and evaluated its effects on breastfeeding and infant development during her graduate studies. And finally, we'll have Elisa Dole. Elisa is the Alberta FICare Family Mentor Program Clinical Coordinator. It's a mouthful. Elisa started her healthcare career 14 years ago as an occupational therapist, and after many years in pediatrics, began to nurture her professional interest in program development and quality improvement projects. As part of the effort to build sustainability of FICare in Alberta, Elisa is drawing on her clinical and project experience to expand access to family mentorship to parents in all 14 NICUs across the province. Welcome, Karen, Amanda, and Elisa. I'm so happy to have you all here today.
Thank you. Good afternoon.
Thanks, Leah.
I'm going to let you get right to your presentation because you have much to share with us.
All right. So I'll start off, and then Amanda and Elisa will conclude the presentation. So thank you very much, Leah, for the invitation to speak to you about our Alberta FICare journey. On this Orange Shirt Day, I'm coming, Amanda, Elisa, and I come to you from Treaty 7 in southern Alberta. So we hope that maybe you'll share where you're coming from in the chat as well. So just working this new platform here. So the Alberta Family Integrated Care Studies were based at the University of Calgary, in Calgary, about an hour's drive from the Rocky Mountains. Alberta has about 4.7 million people. We're adding about 200 people to this province per year, 200,000 people per year. We have about 30% people of color and about 50,000 live births per year in the province. I would like to declare a conflict of interest. I'm the founder and CEO of Liminality Innovations. It's a social enterprise cost recovery created to ensure that the Alberta FICare model is accessible to NICUs outside of Alberta. So our learning objectives today, and we've got a little bit of an interesting wrap on this that isn't present in our PowerPoint. So at the end of this presentation, you'll be able to describe Alberta FICare, which, as Leah explained, is a model of neonatal intensive care that improves quality of care and reduces health system costs. You'll be able to describe the evolution from an idea to sustainment of Alberta FICare, and then describe the introduction of 2 new positions that are essential to sustain Alberta FICare. So let's start with the description of Alberta FICare. The next photo may be upsetting to those who maybe are parents of preterm infants or know people who are parents of preterm infants or perhaps were a preterm infant themselves. So this is Olivia. She was born preterm. So each year, 1 in 10 babies is born preterm. Globally, that means 15 million babies. And this number is increasing. With increasing preterm birth, NICUs do not have enough staff or beds. And in pursuit of life-saving care, healthcare providers often unintentionally marginalize parents, and hospitals exceed budgets. What if all nurses and doctors could open up space in the fast-paced NICU environment for stressed and anxious parents? What if all babies could go home sooner and prevent cost overruns? Alberta FICare can do that. With Alberta FICare, nurses and doctors become, with Alberta FICare training, nurses and doctors become, with that training, parents become true partners in the care. Our training has 3 components. With relational communications, nurses and doctors learn to integrate parents into the healthcare team. With parent education, they learned how to educate stressed and anxious parents. With parent support, they learn to provide psychosocial support and connect parents to family peer mentors. These interactive learning modules are delivered online. Our standardized implementation processes make it very easy for hospitals to adopt Alberta FICare, and regular audits increase sustainability. With Alberta FICare, roles in the NICU change dynamically as parents become true partners in care. One father described parenting with supervision as he was being educated at the bedside to care for his baby in the NICU. When taking her baby home, one mother said, "We started off with the nurses providing all her care. 3 weeks later, we were doing it all." In a cluster randomized controlled trial, of Alberta FICare in 10 level 2 NICUs in Alberta, Alberta FICare demonstrated efficacy for parents, for babies, and the healthcare system. Parents were less stressed, less anxious, less depressed, and more confident. Babies were discharged home from the NICU 2.5 days sooner without more emergency department visits or readmission after discharge. With earlier discharge, the health system avoided less stress. However, these results were from a controlled environment of a clinical trial. We wanted to know what would happen if Alberta FICare were implemented in the real world, with every baby admitted to an Alberta NICU with their family. Building on the success of the cluster RCT, we scaled and spread Alberta FICare to all 14 NICUs, including the level 3 NICUs and the surgical NICUs. And we did this between November 2019 and June 2020. And we all know what happened at that time. So this graph shows that Alberta FICare continues to demonstrate real-world effectiveness with all babies. Since November 2019, we've been monitoring performance of Alberta FICare using near real-time data. And through reduced NICU length of stay, the monthly cost avoidance has averaged close to $200,000 a month. And this is with only 12 of 14 sites fully implemented, because we had to pause the family peer mentorship component during the pandemic. And these savings were realized despite the pandemic and the provincial rollout of an electronic medical record in the province. With the scale and spread, we found no adverse events or harmful results of the rollout. In addition, we found a significant reduction in the 7-day emergency department visits and the 7-day readmissions. Thus, there was no concomitant increases in these counterfactuals that the province was interested in associated with the reduced length of stay. So, how did we move from an idea that was actually scratched on a napkin at a lunch meeting to sustainment of Alberta FICare in the system in just 7 years? And we know from previous experience with the 20-site cluster randomized controlled trial in level 3 NICUs that intervention had limited funding. And, the idea of sustainability in the system that many years ago, 10 years ago, wasn't really front of mind for a lot of scientists and a lot of clinical researchers. So what happened was, when that research funding ended, FICare eroded. And although there were positive results from FICare 8 years after the trial, the leaders across the country were looking for a refresh. And if you look to the literature around interventions, it normally takes 17 to 21 years to implement the results of an effective clinical trial into practice. So this wouldn't be unexpected. And sadly, we know that research evidence alone is insufficient to sustain practice changes in healthcare systems. In addition, researchers are busy enough with compliance, ethics, recruitment, data collection, and they often pay insufficient attention to sustainability of interventions, which should be an inherent facet of implementation based on what we knew about the positive results from the level 3 Alberta FICare. And it was a consideration in our level 2 studies in Alberta. And what we had was an advantage here because Alberta Health Services has what we call strategic clinical networks. And the strategic clinical network that we worked closely with was the maternal, newborn, child, and youth strategic clinical network. And that's where Amanda and Elisa now work. We espouse something called a learning health system, which is a model of care with a defined innovation pipeline to be able to take an intervention from an idea, to put it into a pipeline, to test it, to evaluate it, to test it again in the real world, and then to take it to sustainability in the healthcare system. And so we use this innovation pipeline to help us accelerate our opportunity to sustain Alberta FICare throughout the cluster randomized control trial and throughout the scale and spread projects. The other thing that we were able to use when we were doing this was something called inflection points. And those inflection points are business principles. And they are business principles that where people that are implementing new products in the business world, where they look at key accelerators that transform, that are, create transformative change and acceleration of implementation. So we use these inflection points to watch for areas where where there were barriers and challenges to implementing Alberta FICare. So one of the decelerated, one of the downward inflection points was the pandemic, because we had 2 COVID pauses during the trial. And that slowed our progress because we had to stop going to the hospitals, stop training, and we had to also stop the peer family mentor implementation because families who were not mothers of the babies were excluded from the hospital. But we had so many upward inflection points that accelerated our progress. And I'll show you our model here and tell you a little bit about those and how that made it easy and quicker for us to get through implementation. So to help us think about sustainability and inflection points, we built a theory of change. And we started with the idea of the implementation or the intervention itself and the contextual fit of that intervention with the sites, but also with the characteristics of the implementation itself. So those were important because we had iterative cycles of implementation where we really tried to deeply understand how different sites worked across the province, 14, from Grand Prairie to Medicine Hat. And we did baseline interviews, baseline consultations to find out what the competing priorities were, what their thoughts were about Alberta FICare, whether they thought they needed it, what their capacity was to implement it. So a deep understanding of each site helped us with the contextual fit and feasibility of rollout at each site. The other piece that was very important was a recent paper by Clake, who helped understand implementation in terms of research context, which was our clinical trial, but then again with the scale and spread in the real world. And the things that helped us were alignment with the strategic priorities of the maternal, newborn, child, and youth health network. When we brought trainers to Alberta to train us in FICare, at the end of a day and a half, the providers in Alberta said, Karen, we don't know what to do with that. And so we talked with parents, we talked with providers, and we redesigned the Alberta FICare model based on their feedback. And then we tested it again. Did it work? Did it resonate? I could probably talk to you about half a day on how we did this, but I'll move on. And then I explained the contextualization to the site. Then in the healthcare system, what helped us was that learning health system, was Manira's model to help us focus on the things that were important to implementing multi-component interventions in complex health systems. Our enduring partnerships continue with the maternal newborn child and youth strategic clinical networks. This is what has enabled us to navigate a complex health system that I thought I understood but had no idea about. We've also been responsive to changes, societal changes, and ecosystem changes in terms of updating our modules, updating the literature. And this, the scale and spread governance model, was an entire health system model. Right to the senior executives in Alberta Health Services and Covenant Health, which is contracted to provide services by the Catholic hospitals in Edmonton. Then this intentional integration in the health system. We worked so hard to make it sticky in the health system. Alberta FICare is not going away ever. And Amanda and Elisa can tell you a little bit more about that. And with those efforts, we have sustainment of Alberta FICare. It continues to be aligned with health system priorities. We're now navigating implementation in adult ICUs and other settings for children. We have the ongoing capacity to deliver with fidelity, and the outcomes continue to be maintained. So we're very pleased that process, considering the sustainment and the sustainability, was effective for us to be able to argue to Alberta Health Services, which is the toughest healthcare system in the country, to adopt and fund these two new positions to keep Alberta FICare moving forward across the 14 NICUs in the province. And I will now turn it over to Amanda, who will speak a bit more about her role and how she hopes that these roles will be able to improve the quality of health care in Alberta NICUs. Over to you, Amanda. And just if you can nod when I'm supposed to advance the slide, that would be great.
Thank you very much, Dr. Benzies. I am very excited to be here today to share just a little bit about my role as the practice lead for Alberta FICare. I started this position at the end of April of this year. It is a really exciting role, and to our knowledge, it is the first of its kind in Canada. So some of the work that I'm responsible for includes conducting those fidelity visits and restarting support for units to continue to really embed Alberta FICare as their care culture. So part of this involves monitoring those balancing metrics of length of stay, visits to the emergency department, or readmissions after babies have been discharged from the NICU. Among other things, I have redesigned a parent experience survey to be utilized for unit feedback. So that's really important to get that parent voice and really help to kind of drive those things from that parent perspective. So I'm really excited for that. I have revamped the parent journals to include parent resources surrounding caring for their baby, participating in rounds, and really supporting maternal mental health, but also as that keepsake to record special moments while they're in the NICU. I'm just about to begin the next annual update of our learning modules to ensure that they remain current with best evidence-based practice and examples that are helpful for staff. And then I also make sure that the information on both the internal and external FICare web pages remain up to date. The absolute best part of this role so far has been visiting each of the NICUs across the province. It has really allowed me to just identify those different elements of practice that are truly representative of those FICare principles. And it really gives me an overview of the province as a whole, but identify those really specific elements of practice that are continuing to propel FICare and how I can spread that to other NICUs, just as really great ideas and tidbits to just move it forward as a whole. It's been really beautiful to see the way that the NICU staff are working alongside their families and empowering them as they kind of work their way through this journey. So that's just a little bit about my role. It's been really great. And I think Elisa's got a chance here now to tell us a little bit about her role.
Yeah, thank you, Amanda. So yeah, my name is Elisa, as you've heard, and I'll try and share succinctly my role as a family mentor coordinator. I'm trying to shorten it every time I talk about it because it's a mouthful. I also started this position at the end of April of this year. And I think it is important to situate this work sort of temporally. So we're really only a few months into what will be at least a 3-year effort to ensure this program is sustainable. And as you heard from Dr. Benzies, the family mentor component of the parent support piece of Alberta FICare wasn't included in that scale and spread, right, due to the COVID-related restrictions. But because this is such a crucial element of the support that parents can just really benefit from while they're on a NICU journey, I was brought on to ensure this is developed to the extent it was initially intended. So that is for all parents in all NICUs in Alberta to have equitable accessibility to family mentors and that lived experience of the NICU journey. So the sort of front end work I've been doing is similar to Amanda's in that I'm just involving sort of gathering best practice evidence and doing what I'm calling an environmental scan of what sort of the current state of family mentorship is in Alberta right now. So looking at literature and talking to all kinds of people to understand where family mentorship currently is at in the province. And also getting to know all the different ways that it's offered at sites across the country and actually globally, which has been so awesome to see how both similar and different the approach is, but how universally important and effective this work is. There are certainly many different options for how this mentorship can be delivered, and I've gathered lots of insights already. To give you some background on where it already exists in Alberta, namely only at a handful of sites in the major urban centers. It's kind of a combination of on-unit, in-person support provided by a volunteer peer mentor or phone-based support through sort of matched dyads of families and peer mentors, and then both in-person and online groups. And these have been variably successful, especially during and following the pandemic. So I'm really considering peer family mentorship as being relaunched in all of Alberta, as it does seemingly continue to be everywhere. So next steps will include co-developing a family mentor model with parent partners and NICU staff, and finding what will be appropriate for the individual NICU sites. So as Dr. Benzies alluded to, each site is very unique. And so the program will need to be simultaneously consistent across the province and equitably provided, but also individualized to the very unique cultural and environmental context of each site. So I have high hopes that around this time next year, we'll have developed a model to trial in some, if not all, of the sites. And I certainly expect my role will continue to evolve, and the need for an overarching provincial support of the programming will become more clear as this project advances. That's about it in a nutshell. I also am just so excited by this work, and I think there's just so much potential. I can't wait to see where it goes.
Alberta FICare as a model is improving neonatal care by involving parents more actively. We've highlighted the importance of designing sustainable healthcare interventions, which culminated in the funding of our 2 positions and really underscores the ongoing support for such initiatives in complex healthcare systems. The next few years for Elisa involves, as she said, designing, implementing, and evaluating that province-wide peer family mentorship program. For myself, monitoring the extent of those sustained benefits of Alberta FICare, those lengths of stay reductions, the reduction in emergency department visits, and fewer readmissions. That work is ongoing, and it will involve tailored unit level support to kind of uphold those practices and principles of FICare. For Alberta FICare in a broader context, there's always the opportunity to impact more families through an equity, diversity, and inclusivity lens, or expanding to other healthcare settings like pediatrics. The adaptation to inpatient pediatrics with a focus on children with medical complexities is funded and moving forward. Yeah. The future of FICare is really exciting, and I'm really honored to be part of this kind of next chapter of FICare as it moves forward. Yeah. We are so grateful to the families of critically ill newborns and hundreds of people who have contributed to the Alberta FICare studies.
And, oh, yes.
Yeah, and we have just selected a few of our team and trainee publications that if you wanted more information on any of those, just reach out and we would be happy to send you off anything in person. But we would just love to welcome your questions and comments about where we're at, where we've been, and where we hope to go. So thank you very much for that.
Thank you so much for your presentation. I'm just leaving it up there for another couple seconds so people can see Karen's email address up there to reach out. But wow, you all have taken on a very major project and very ambitious to even reach all your NICUs in Alberta. And so I'm just wondering, when this first started and you were looking at where every NICU was at with their FICare journey, was there a lot of variability, or did the NICUs tend to be all on the same page with this? What did you discover?
We discovered that there was a great deal of coherence in the quality of care in the urban sites. And we suspect this might be because the neonatologists here at the urban sites, the majority of them, we do have a small number of community pediatricians covering who want that sort of a neonatal experience, but the majority are salaried neonatologists, and they the standard of care across the urban sites, and Calgary and Edmonton are slightly different, as Amanda will attest to. But that standard of care in the urban sites is pretty coherent. Where we found more differences was in the regional sites. And those regional sites, and then this isn't just because they're served, like it's not just the physician model, but we've always run every implementation, we've always run it in parallel with the medical director and the hospital executive director and the NICU manager. So we've always balanced it. But we know that physicians, will drive, innovation at their sites. The regional sites are served by community pediatricians who also have busy clinics caring for children across the age span, not just children in the neonatal intensive care unit. It makes it really difficult for them to do bedside rounds, huddle at 8:45 and do bedside rounds at 9. And then the regional sites are served. The social worker will often serve, emergency department and maternity. And so it's a question of those differences are driven by, resource allocation and some of the structures at the regional versus urban sites. So, but then again, within each regional site and within each urban site, there are also nuances of care, differences. There's different champions, and they take it up a little differently. So understanding that, a deep understanding of that, is what we were able to acquire in those quarterly fatality visits during the trial and during scale and spread.
Even that in itself is a huge achievement, to kind of almost do a temperature check of all the NICUs and how they're doing with implementing FICare.
Yeah. And the managers were, we thought, oh, they're going to just, they're not going to really like it because we're coming and we come with our paper and our clipboard and we're watching. But the managers, by and large, saw this as a real advantage because, they have to manage, the parents who are concerned about the quality of care, or they're the people who actually truly understand the importance of the quality of care and making sure that parents are included and valued members of the team. And we could go into a lot of detail around the feedback we received from parents from our two major parent advisory councils in the province, but we won't. But the managers would say to me, "Oh, Karen, thank goodness," because the nurses get tired of Allied Health, and they get tired of me saying, "You need to change this. You need to do better in this." She goes, "You've been here." I could go, "Karen says you need to get better at doing that." They go, "Thanks for relieving my burden." But it worked. We worked respectfully and honored their competing priorities, and we fit things in, and we showed up. And when the FICare super users couldn't keep up with the data entry, we sent nursing students down to Lethbridge for a couple of days. They had a blast, collecting data in the basement of the hospital. We just made it work. And then the most important thing, I think, and Amanda alluded to this, is we built it sticky. So for the FICare super users, we as nurses, we need to renew our licenses every year. So we went through all of the things that they needed to report on. We fit in all of the work they were doing as FICare super users, and we said, here, you can report on these things in your annual RN license renewal. Healthy Parents, Healthy Children, they built us a NICU web page on their web page. Amanda's taking forward the work we started because we undertook an electronic medical record, and the parent education module for that is not sufficient for training, for educating parents in NICU. So they're updating that. We're building it sticky. It's not going to go away.
Elisa, you had talked about the component of the peer mentorship, and that is kind of your role at this point. And I'm just wondering if you could connect the dots for us a little bit between the idea of family integrated care as a model of care and then this kind of hand holding with the peer mentorship. Why is that an important component to this program and its sustainability?
Mm-hmm. So the way that we look at that sort of parent support piece is that it's sort of a hybrid, right? So parents are accessing support on the unit through what's clinically provided by social workers, psychologists, etc. But there's just really no substitute for that lived experience. And so parents will talk about how more accessible it is to talk to somebody who is not in charge of their baby's care, and maybe who they're having a disagreement with, or they're not totally understanding what's going on. And so I think it's just that the relatability of the different person. I've been using this quote a lot lately, but something that came from Amanda, I think, is that we're reminded that, for healthcare practitioners in the NICU, it's just one day. It's a day of work. You go in, you do your job, you leave. But for parents, it's day 1 or day 7 or day 100 of what can be, a long and lifelong journey. And so every week, probably that's evolving for them. And so I think it's the parents are the ones that speak about it. They say it's not, you don't know that you need it until you experience it, and then you understand what that experience is and how crucial it is. Yeah.
I was very interested when you guys were talking about moving into the area of pediatrics. And then I think, Karen, you even mentioned adult ICUs. And so I'm just wondering, when I think of FICare, and as someone who experienced FICare in NICU, it was very much about the relationship with our baby and the bonding, and something that you think like only parents can have with their babies. And that was kind of the propeller to get us out of NICU and all those advantages we talked about. But how does that work in the adult world? Does it translate in the same way?
Not perfectly, which is why in the inpatient pediatrics project, with a focus on children with medical complexities who, are sometimes NICU graduates, that we need to go back and we need to work with families, work with parents, and we need to adapt. And there's very good literature on, they call it an adaptome, but all of the pieces that we need to pay attention to. A master's student has gone through all of the training modules, the NICU training modules, to see what needs to be changed. But the processes may need to change as well, because these children have been at home and they're coming back to the hospital, and the parents have been confident in the care of them at home, and the child has had an exacerbation or fallen ill due to picking up a virus from an older sibling. And so we need to carefully look at the population, because when you're doing adaptations, it's the population and the setting. So the ratios, the nursing care ratios in inpatient peds are different from NICU. So there's a lot of things that we need to consider. With the adult ICU, they are working closely with families and discharging patients directly home from the adult intensive care unit. If the family is willing and ready and confident to learn whatever care needs to be undertaken. And this then avoids that transition to a step down unit or to another level of care in the hospital. But the similar kinds of things in the Alberta FICare model, you said communications and relationships, and some of those papers on the list you will see are about communications, and the differences that how mothers experience the differences in relationship between nurses who have and allied health and doctors who have had Alberta Family Integrated Care training and those who have not. And it's about the relationship. So in adult ICU, it's about the relationship, the trust. It's about the education. And no, it's not about jaundice and vitamin D, but it could be about that PICC line, or not the PICC line or whatever. I'm not an adult nurse, so whatever it is that the adult needs. And so it's education, and then psychosocial support, because families are stressed and anxious when you've got someone in the hospital with who's critically ill. The support for those families is important. So those three bubbles will still work. It's just what's in those bubbles that's going to have to be adapted. And then the rollout will have to be adapted. The other thing about pediatrics and NICU is that parents of young children expect to provide care and support for their child till they're 18 or maybe 30, you never know these days. But they expect to provide care and support. A spouse, a friend, a sister may not want to be able to provide the kind of support that an adult might need coming home from ICU, from an adult ICU. So those differences in populations are something to pay attention to.
Amanda, I'm just thinking you were kind of boots on the ground when you were scanning the 14 NICUs. And I mean, you have all said it's a relatively new project, but even in this amount of time, what has been most surprising to you in this experience as a takeaway for yourself?
Oh, all of it has been surprising. I think you have a set of beliefs as a NICU nurse, but when you go and you speak to families one-on-one across the board about what it has been like for them, and you hear their stories when they've been discharged, it changes you in a way you can never go back. And that really has been that driving force. And you see that nurses want to provide that care, the healthcare team wants to provide that care, and all of us are on the same page for that. Like, the family is our goal. Families say that, like, I am so grateful that I had such great care. That's been a universal statement, which is really makes you feel proud as a healthcare provider that you're making these steps in that right direction for them, and you put them at that forefront. It's still kind of shocking that it can be so different as a provincial healthcare system, that each site is still so nuanced. You're like, but wait, we're provincial. How come this is still so different? Why do you have these resources and these ones don't? And some of the inequities, you're just like, oh man, it's 2023. Why are we still here? But it's just been a really eye-opening experience and very humbling to hear that the work we're doing is making a difference in every family's life.
Well, I have to say, I see the passion as you all talk about it and the excitement, which, I mean, certainly helps in driving a project like this forward. And I just, as my final question, you've been doing this for a few months now, and you mentioned that it is a 3-year effort at least. What do you want to see by the end of those 3 years? What are your best hopes for Alberta FICare? It's a big question.
Maybe Elisa will start as I percolate a little bit more.
Oh gosh, dare I say that I work myself out of a job? Like, that there's such support that, yeah, you know, that each site, I mean, I don't really believe that. I think there's always going to be that need for that community building piece once this is sort of up and running at all the different NICUs. But that they are each sort of self-sufficient, and that there is an established process, you know, for, I mean, in my case, the family mentorship piece, and that we're leaning on each other. So I think Amanda alluded to this, that even in a provincial program, the units can be a little bit siloed in ways, right? And so, and family mentorship is one of those. And so I think if we can build a bit more of a community of practice, so that there's backups, and that we're using the strengths of the urban sites to support the regional sites, and that it truly is sustainable. I'm not just saying that because that's what, you know, maybe AHS wants to hear, but yeah, we'll see if we get there in 3 years.
It would be great if it didn't need us, and it just is the way care is delivered, and that nobody thinks twice about how to incorporate the families and put them at that forefront. Families don't think twice about talking during rounds and asking those questions and advocating for their babies. But I think there's always that opportunity of pushing that farther. Like, how do you reach those families that aren't able to come in? What does family integrated care look like for the ones that are challenging to connect with and reach? You know, they've got other babies at home. How can we continue to push it, keeping those families at the front of our mind? So I'm optimistic. I'm excited. It's been really, really, for me, this idea of expanding it to pediatrics, because these families often go there next. And so when they've been so used to having that voice, and then you go to pediatric unit and it's just like, wait a minute, this is different. I absolutely can advocate. I know my baby best. Like, why do I not have that same voice to carry it forward? Makes sense to me. They are the experts in their baby's care. They are around all the time. We're there for such a short snippet. So just continuing that empowerment of them. Yeah, I think there's always more we can do. I'm excited to see where it goes.
Mm-hmm.
And Karen, do you have your big dream for the next 3 years?
Well, they don't need me anymore.
True.
And it's really a bit of a challenge for me to get my baby fix. I'm sorry to say that word, but I was trained as a midwife and a nurse, and those special times in the NICU just to see and not touch, but at least I can look and talk. That I'm pulling back a little bit more from that, but I do know, because Amanda and Elise are quite capable with leadership in the MNCSEN, the Maternal Newborn Child and Youth Strategic Clinical Network. They're quite capable of carrying this forward, and I think Amanda was a super user for the clinical trial, so she's done this work for as long as I've done it, and so in a different way. So the hope then, we know we've changed the culture in Alberta. We know we've changed the culture in Alberta, but I think that change is somewhat fragile, and that we need to work with Lisa and Amanda's help. We need to really work at making it just the way we do business, because it's sticky, but I want it to be really sticky. And that I've heard anecdotally nurses coming who are hired to NICUs in Alberta, going, what are you doing here? That's so different. And so that's affirming. My dream is that Alberta can share this work to all NICUs in Canada, so that every NICU would have an opportunity to be able to provide care like to families like we do here. I jokingly asked Alberta Health Services, knowing the answer, now that Alberta is scaled and spread and this is the standard of practice in this province, let's get all the nurses and doctors and allied health folk from across the country to log into Alberta Health Services to do the training. And they didn't like that idea. So we have to find another way, but we will, because we're determined. Amanda said it best. The babies, the parents, the families, those are front of mind for us. Whatever we can do in the next 3 years to leave the world a better place for those people, I'll be happy with.
Well, thank you all so much for joining us here today and for sharing about your initiative. Like I said, very timely time to be talking about this with the International FICare Conference happening this weekend. And we did have someone joining us from New Zealand who said her unit is currently looking at implementing FICare, so timely for her as well. So thank you all for joining us and for sharing your expertise today.
Thank you, Leah.
Thank you very much.
And thank you, everyone, for joining us. I just want to remind you that if you'd missed any part of this program, you can see the whole thing at CanadianPreemies.org, and you can also see past episodes there as well. I also would like to thank our sponsor, AstraZeneca, for their ongoing support of this educational program. At this website, CanadianPreemies.org, you will be reminded that CPBF is a charitable organization and it depends on support to continue its important work. And so consider how you can support CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a better future for our preemie families. Join us here next Friday, same time, same place, 1 p.m. Eastern Time. We're going to talk about growth and very preterm infants. Is bigger better? I hope that you don't miss it, that you're able to join us. And I also wish you all